Thank you again. Right, thank you for your wonderful introduction. Good afternoon, everyone. Welcome to the afternoon session of IDEM. Thank you, AOHT, for inviting me to share my experience managing cases from children to adult, right, in terms of sleep dentistry. I'm going to try to break this topic down quickly, right, into what we are looking at now first. In terms of the sleep-related breathing disorder, I'm going to help you to define it and understand that component. And then we look at also how we can involve the OHT, right, in terms of early detection and also management. But because the topic is so huge, I won't be able to bring in too much of the dental or the dentist approach that could include also myofunctional therapy and also mandibular advancement devices. So that part, I'll leave it to another day that will dwell more into it. Okay, so for me, I'm a general dentist, graduated in 1999. So I'm very curious, so have been a course junkie all my life. Finishing my fellowships, doing my implant training, TMD training, laser training, myofunctional training. Then I went on to do a TEDx talk, right, in 2017, which really tried to put tongue, right, as a very important aspect of health. And of course, the dentists and the oral health professionals, we can do a lot about it. And I also helped Invisalign design some part of their CleanCheck platform, and also have been their panel of speaker, but recently retired from it. And I teach at the University of Sacred Heart in Rome as a visiting professor on the topic of lingodontics for my colleagues who are doing the master degree for laser dentistry. So the discussion of the tongue is very important as an overall aspect of health again. And I'm very fortunate also to sit on the board of the advisory panel for the nursing school, for the oral health therapist school. And hopefully, like I say, I'll be able to, over my tenure, help to change some perspective and bring on new roles, right, for our oral health therapists and hygienists in Singapore. And I also sit on the panel and editorial board for the International Journal of Myofunctional Therapy. Okay, so I'm going to jump straight into it to give you the answer or the conclusion of this lecture, myofunctional therapy. All right, so I think the key thing is, how can an oral care professional, especially when the oral health therapists, they are seeing many children, how can they detect all these issues early and then offer some suggestion, sometimes opinion, and do the right referral, or maybe even if they get themselves trained, right, to be able to perform the therapy to help the children, right? And of course, this therapy is not restricted to pediatric cases only, but also for adult cases. But it has been a difficult push over the years to get this part recognized as a therapy to be used for sleep-related breathing disorder or OSA. But thankfully, this is what we have now, all right? This is gotten off the website from SingHealth. We have our SingHealth group, sleep medicine department, now purporting and promoting, right, myofunctional therapy and nasal breathing as a very important adjunctive care, right, for our patient to overcome the issues of snoring, apnea, and even maybe upper airway resistance syndrome. So we are seeing here a set of exercises that they have already chosen, some on the tongue, some stretching of the tongue, gum chewing, tongue forces, and also tongue clench. But point is that you can see a lot of emphasis is on the tongue. All right, so the tongue has to go up to the roof of the mouth when you sleep, so that it doesn't falls back and block your oropharynx, just like what you see on the screen here, on the right. And at this moment, the hospital setting is still unable to provide the full support in terms of the physical therapy, but they're already providing all these brochures, and they're also trying to develop an app so as to help the patient, right, learn about all this as easily, as cost effectively as possible, right? But without guidance, it might not be the easiest of thing to perform and learn, and sometimes to sustain that training in order to see the results. So over here, they highlighted a few things. Is a set of exercise for the throat, butt and tongue. But I want to emphasize that there are also the need to also train the lips or the opercularis oris, right? In order to form that lip seal. And what it's trying to do is to increase the tone and strength of the upper airway muscles. This is also being identified as a very important area to help us breathe day and night. And if you can do it well, right, it reduces your daytime sleepiness, it helps you with your reduction of snoring and improve obstructive sleep apnea. Definitely is complementary to OSA treatment. So how did this all started is we were on that fateful day. Yes, Dr. David Tay here in the audience was also presenting in this conference on that fateful day and fateful year in 2017 when the late Professor Christian Gumino was here for the SGH Sleep Conference. It's actually a conference for the sleep physician, but a few dentists are already involved. Dr. Tay is giving, Dr. Mimi Yao is also lectured, and I was attending, right, as an attendee. But it was quite groundbreaking because Professor Gumino was there to put on this slide to say, so as a physician, as one of the lead researchers for Stanford sleep team, he said, persistent mouth breathing is never normal, right? Oral breathing is going to cause all kinds of issues, including frequent infection, right? Malocclusion, incorrect phonation, right? Abnormalities of body posture and changes in sleep. So there are also more and more research coming through as time goes by. You can see mouth breathing is the etiological factor for sleep disorder breathing in children. And mouth breathing causes airway obstruction, or should I say, let me put it another way, associated, right? Mouth breathing, airway obstruction, craniofacial abnormalities. So we're still trying our best to actually form the strongest of link to all. So in 2017, I took on the most difficult lecture I've ever given, right? To give a TED talk, right? In a short 17 minutes or 18, right? I had just to get everything right and get the story going. And just to say, look, we can be strong, we can be healthy if we take care of our tongue. And also at the same time, I was doing some work with the NTU School of Information. Actually, we are trying to bring this whole idea of pediatric obstructive sleep issue to the community. So we had a lot of community work done, right? And there was a book that was also published then. It's called Guardian of the Night, right? And we are the guardian. And who are we? We are the hour. And what are we doing? We're observing, right? So using the acronym of OWL, we are looking at observing restless sleep. So the child is actually moving around, a lot of toss and turn because they're always in light sleep, can't go into deep sleep due to the fact that they just can't breathe well in certain position. Next also, we look out for unusual sleep posture. So this kind of sleep posture could include face down sleeping with the butt tipped up, or they can be even hyperextending their neck, right, in a very awkward way, right, and of course with mouth open, drooling, and really uncomfortable to be honest. And we listen out to regular and frequent snoring. So one of the key points to look out for is, are they, right, snoring more than 3 nights per week. And if they are, they should be, this alarm bell should be raised and they should be brought to like the relevant physician to have a check. All right. So this is also another paper that was published in 2015, right? In the past, all this thing happening in the past 7 to 8 years, 10 years. Again, Kamoko did this systematic review, and the conclusion is really very enlightening and also encouraging that if we can change this habit of ours, right, it can improve more than 50% of your breathing by reducing the AHI, the apnea-hypopnea index, in adult for about 50%, in children about 62%. A lot of work done, half the job done if you can change habit thoroughly, all right? And this paper was published in 2020 in the Sleep Medicine Journal. And it talks about pediatric obstructive sleep apnea beyond adenoid tonsillectomy. So adenoid tonsillectomy has been performed on children when they are snoring for the past almost coming to 100 years. Right? It has been just the standard. Find a child, if they're snoring, if a pediatrician or any physician refer to the sleep physician, they might perform a routine adenoid tonsil removal or partial removal for them. But over here is sharing some points. 60% of the children will experience residual issue. All right? Short term, you might have divergent outcome. And for long term, there is no benefit. Then my question is, why cut in the first place? But some cases, we need to do some emergency or very short-term surgical intervention in order to really help them. But I'm just saying that there might be also other opportunity to intervene differently. And of course, CPAP is also one of the gold standard or first line kind of treatment for children and adults for sleep apnea. However, for the child, if you keep on wearing a CPAP machine strapped close to your head and limiting the growth, right, you get facial alteration. Then what is being supported here in a medical journal is a dental approach, maxillary expansion, oral appliance, and myofunctional therapy. So we can see that definitely from the perspective of a dental oral professional, we have a role to play. So if we try on this face mask or nasal mask sometimes, right, let's say it's very restrictive. How about we try getting some exercise or habit change, because it can help to improve. Like for example, this is another paper, myofunctional therapy on children with OSA meta-analysis, also highlighted that despite the differences in exercises, right, myofunctional therapy can decrease AHI by almost 43% and increase mean oxygen saturation for this mild to moderate cases. So I think it's a good and safe way to try. Yesterday, I was just attending the lecture by Professor Chris Peck, and he was talking about 3 points, right? Hopefully, like you say, is evidence-based, is reversible, and is cost-effective, right? So this area, the only thing is that I hope it's not reversible. If you change your habit, I hope you keep your habit, the good habit, so that you can really breathe well. So, but generally, if we can work on this, look on a community level, for example, you can imagine if all the schools, we have therapists, getting them to do an exercise like this. A teacher come in, they say, okay, imagine you're the class. Everyone, keep your mouth closed, breathe through your nose. Then your classmate will be like, hey, teacher say, close your mouth, close your mouth. And then if you keep doing that, right, while let's say you start at primary 6 or should I say primary 1 at 6 years old, and as your teeth are erupting over the 6 years, right, this natural function is guiding your growth. what will be the outcome? Not only that we are healthier breathing, can we have a better face form, dental arch, better alignment of teeth, among other things that is actually influenced by this whole process, right? So let's keep that thought thinking. Also another meta-analysis in 2022, right? Again, highlighted that oral and facial muscular function therapy can be used as a simple and non-invasive new technique to improve AHI, minimum oxygen saturation case, right? Your was also improve, your snoring intensity also drop for mild to moderate. So I think it's a very, very, very safe thing to apply. And who should do it, really? The verdict is still out there, you know. There's no one that is really taking care of this piece of the pie, right? And I always feel that anyone knowing the oral environment should be involved. Oral health therapists, I think certain work, right, might be in collaboration with this in terms of understanding the function well and adjusting that. But there's another group of people, the professional like the speech therapists, they are really primed for this role. They are already doing all the treatment, right, in terms of speech therapy. At the same time, they are very well versed oral motor skill, reflexes, and behavioral management, right? And they definitely can actually apply all the experience and know-how and add on with the myofunctional understanding. And if they are with us as the dental professional, knowing the dental structure better, they are again another level in terms of experience and understanding. And if they work with the dental together to help with the adjunctive treatment for the ENT or the sleep physician, that is again another level of understanding how the craniofacial form will then facilitate breathing. I will go in a little bit more into the anatomy a little bit later, right? Just to now lay the foundation in terms of the research and the evidence-based component for you. So, of course, when we try to treat a pathology, the first thing I always ask is, do you know what is a normal sleep architecture, right? How do we look like when we sleep, right? So, if we just observe with our naked eye, of course, we can't tell many things. We need to go through a proper polysomnogram, a sleep test. Then certain channels include your brainwave, your breathing, your heart rate, among other things are being tapped on and checked on. Then we have a better and more complete picture of your sleep performance, especially in the area of breathing. So if we break it down, we are generally about like this in terms of the percentage. So you have about, that 5% into your stage 1, and that's between wakefulness and sleep. Anyone in this stage now already? After lunch? Anyone? Okay. So after that, you go into a deeper stage, and 2, this is about almost half, right, of our time in sleep. Longer sleep phase, all muscles starts to rest. Snoring may occur already. All right. Then you respond to stimuli is suppressed. Then the brain consolidate information and learning for the day. Then we go into deep sleep, right? This entry, deepest phase of sleep, consolidate long-term memory, and you learn new things and you are activated in that. And finally, you also have your REM sleep, rapid eye movement, atonia, vivid dreams, right? So we are into all these stages, and if we do it right, we will spend about 90 minutes to go through all these stages per round, right? So if you can squeeze in the 3 or 4 rounds of this, you feel good, right, sleeping. But sometimes if someone wake you up right in the middle of it, that's when you can get really edgy. So the nightly pattern, right, we go in and out of this, 90 minutes per cycle. Sometimes it can extend up to about 110 minutes as well. Okay, so it's too big a thing. Just scan the QR code request. I'll give you my 10-page summary of the sleep architecture, and we'll share it with all of you. Right. Okay? All good. Right. So sleep can be disturbed because of air shortage. Of course, there are many, many, many reasons. So in the book of sleep, sleep issues, I think there's about 3,000 disorder, if I'm not wrong. So I'm concentrating more on the fact that on the area of air and breathing, right? So what's the problem? I look at this whole situation as a spectrum, right? So we have the start point of mouth breathing. So you open your mouth, breathe, but sometimes it's not always mouth breathing. You still breathe through your nose, but just the mouth is open. But if you can try it out yourself, breathe through your nose, open your mouth slightly and still breathe through your nose, it doesn't work that well already, right? Yeah, it's just like a pipe with an opening and the suction is just not good. Breathing through the mouth is easier, 50% less resistance, but you just don't go through the correct activation of chemoreceptors, pressure receptors, right? And activating your whole body to breathe well. So we're not just talking about channels here, not the mouth or the nose only. It goes deep into the whole aspect of how your body actually breathes. So when you breathe through your mouth, sometimes you sound like this. After you get into a deeper stage of sleep, your muscle is getting really relaxed and you go, yeah? And then if you get a little bit more relaxed and the airway gets really narrow, you go, so you're really wheezing and trying to push the air through. And then finally, yeah, so you stop breathing for a while. If it's a 10-second, okay, you got one apnea, right? So nobody, I feel, always stays in OSA for a whole night. That person won't survive, right? So it's always falling between all this, and of course, the different condition will make it better or worse, right? If you have a drink, exercise a lot, and of course, your physical state in terms of structure and anatomy might predispose you to issues. But we lump all this down now together as sleep-related breathing disorder, as rather than to be just speaking about OSA particularly, because I think we need to address all the other issues that is causing hypoxia, difficulty in breathing or restriction in inspiratory airflow. So sleep-related breathing disorders are characterized by disruption of normal breathing, potentially serious medical condition, because really, once you don't get enough oxygen, your whole body is going to complain, right? First thing first, you get your heart pumping really fast, and then to help with that, you have your blood pressure going up. You need all the energy to keep you going on at night like this. So you have to release more sugar into your bloodstream, and then your insulin has to be pumped out to clear that. And then while all this waste is being created, your liver, your kidney, all has to continue to work hard, right? Your body hope you are just having one night of party. But if you keep this going, right, it's going to be very, very tedious and taxing for the system. Just to think about this, you need oxygen every moment because you need energy every moment to run all your physiological activities, right? But if you don't have oxygen, that's the limiting factor. Where are you going to get all the energy? You can't. But you still need it. How? Then you have to go into anaerobic, right? No oxygen. You dig deep into your body, and that could be 3 times more energy than the aerobic type. Okay, so that means when you wake up in the morning, you owe your body, right, the energy that you didn't produce, plus the energy that you dig out from reserve. So you're always like, oh, no strength, very tired. And what is the first thing on your mind to replenish this? I don't think you would like, okay, let me sit down and I'll breathe first. No, right? Most people say, oh, let me look for some food. And true, research show that we will go for the high caloric food in order to replace that energy. So sometimes we might be eating unknowingly and putting on more fat and weight, trying to replace that energy, but it is the limiting factor, oxygen or air, not food. So when you have mouth breathing, you breathe through your mouth, then you have the snoring. Upper airway resistance syndrome, I think we have an expert here, Dr. Tay. It is still, I say, we will just need more research into it. But I think suffice to say is just that it is just that whole breathing between the snoring and the apneic type. You don't stop, but it's very hard to breathe. And we are now using other indices or index to actually check on this aspect. All right? So OSA, we know, is going to cause cardiovascular, respiratory, dental, other diseases. In children, undiagnosed and untreated OSA can be associated with all this issue, but it impairs growth. It also makes learning difficult, and it changes their behavior. Right? Sometimes ADHD can be also associated with this as well. Right? So we need to really put attention to this aspect, and sometimes the intervention is not difficult and, like say, relatively cost-effective. It's just that we just need to pick them up. So we have the standard apnea-hypopnea index that has been used for many years, but we all recognize that it might not be the best thing to have, because it just splits things up like this, where when you stop breathing for 5 times or less, is considered normal. And then you have your mild, moderate, and severe, depending on the time of stoppage or how many stoppages. But let me just ask you this. Imagine you do AHI 5, okay? You're still normal. But every 12 minutes, you will stop breathing for 10 seconds or more. Do you want that? Right? So it's not about just saying it's a normal, mild cases that we don't need to then treat. It's about we are already showing signs of it. Can we do something now so that it doesn't get worse? Right? Muscle strength can get worse, right? More flaccid, more habit can get worse. Arches can get more narrow, collapse, retruded, position of the head, all this can get worse. Can we do something so that it won't get worse? Sorry. So, for UARS, upper airway resistance, we're also checking more on the respiratory disturbance index. So we're also trying to understand, okay, how many times you get microarousal aroused through this very difficult effort to breathe, respiratory effort-related arousal, RERAS, right? And so that is included. And also oxygen desaturation. That one is very standard in terms of like looking at your oxygen saturation dropping from 100 to 97 or dropping down to 96 as part of the cutoff mark for insurance claim in other countries. And or they check at how much time you spend below 90% saturation. Yeah. And also look at your lowest saturation. How long can you hold your breath until you get a 67% oxygen saturation in your blood? How long can you hold your breath to do that? So when all this is being reflected in the report, then you start to worry as a person who goes through it, that you can literally stop breathing for such long time throughout the night, right? It's very taxing, like say, at least for your heart first. So for what's the incidence? We're really looking at about 12 to 15% of children affected by this issue, between 3 to 5. And in 2% of the children and 2.5% of the adolescents having the pediatric obstructive apnea, they appear having all these things early. But again, you see, sometimes parents are even laughing and they're making videos of their kid snoring in their sleep. They're like, ha ha ha, so cute, right? But we have to be worried. We have to be really, just now, later on, you will see one of the slides. It says we have to have very low tolerance for this. We cannot allow it to happen. And if we really check, we will definitely find more than this number. This is just what was published. So during COVID, since I got a lot of time, so I started calling up many people. I asked them, because in the market, we have rings, we have bracelets, we have wearable device for adult to test their sleep issues. All right? There's nothing really for children. Yeah. Then I asked this particular company, actually imagine Kodak. Kodak is doing something. They're no longer doing film only. They're doing this mat and a camera. So you put a baby on it, you'll be able to check on the breathing rate and temperature and all that for the baby. So I asked them, can you then do something for children, wearables or a mat? And the reply is, the market is still too small. Unfortunately, we don't have the resources to build for them. So at this moment, we are still not addressing the issue properly, just like the last point here, due to lack of resources to adequately diagnose all this sleep-related breathing disorder for children. We are not picking it up enough. So what else can we do then, right, to really see it? So thankfully, the Asian pediatric pulmonologist perspective came by, all right, led by Dr. Daniel Ng, and we have this published a while ago in 2017, right? So the joint effort on children for OSA, right, by the Asian pediatric pulmonologists, what they have done is this, all right? They recognize, yes, it is 1 to 5, but they know that we need to do more and there will be more children. And the management include up-to-date statement cover most important OSA regarding diagnosis, conservative treatment, adenotonsillectomy, orthodontic treatment, and orofacial myofunctional therapy. Thankfully, again, the medical fraternity is, looking our way, right? To say, hey, we can help out in this area. So then we have this diagnostic criteria for childhood OSA 1 to 18 years old. So this is a good table for the screening tool that most of us can actually refer to. So I think simple to ask is, actually even before you ask, when you walk into the room, you look at them, mouth open, mouth closed. There's already one big risk factor. And there's no half closed or little bit open, no such thing. As long as the lips are not sealed, you cannot preserve the negative pressure within the mouth to create the suction force to hold the tongue up. We need lip seal, all right? So we check if they're snoring, there any labored breathing, daytime sleepiness, pediatric hypertension, nocturnal uresis, are they wetting their bed, right? Excessive sweating, and chronic non-REM parasomnia. And sometimes they just wake up, cry, make a fuss. They don't even know they do it, and you can't wake them up, right? So then for criteria A, we go through one or more of the following, all right? One or more. One already you can even make it into a diagnostic criteria. That child is at risk. Criteria B, PSG. So we do a sleep test and then we found if the AHI is 1, just 1 episode, they are having issues. So again, very low tolerance. We are not going to give them 5 and they're still normal, right? Okay. So you can see in another enlarged version of this, criteria A. So these are, I think, things that we can ask our patient and if we really suspect them of having possible sleep-related breathing disorder. All right. And then criteria B is more medical, right? They definitely have to go through a battery of tests in order to get very clearly diagnosed. So risk factor for childhood obstruction of breathing, micronectia, mid-face hypoplasia. Do we see that in our patient? We do, right? Sometimes that undersized lower jaw or a maxillary hypoplasia. If the tongue doesn't get up to the roof of the mouth, upper jaw is going to get smaller. Class 1, normal issues. Class 2, upper jaw small. Class 3, upper jaw small. Yes? Yeah. So when you look at it, these are the issues of contributory factor, shall I say. Then congenital lack of teeth. Then they have short lingual frenum. So a restrictive lingual frenum, of course, we call it tongue tie as well. But tongue tie to me is very absolute, right? It's like, yeah. Then restrictive, now we can look at it in a broader sense. Then we have chronic mouth breathing. All these are included into assessment of their risk. And neurological morbidity, cardiovascular morbidity. Of course, we look at a whole picture in medical perspective. And then diagnostic approach, really screen for presence of snoring 3 or more nights per week. Just ask, parents, are they snoring? And symptoms are all there. Learning, attention deficit, right? Yep. Okay. You see the list. I mean, sometimes I say the abnormal has become the norm. Yeah. And sometimes when you discuss all these things with the parents, they say, my elder child also does it. Oh, my neighbor's son also is like this. So everybody is like this means that we are okay to be abnormal already. Yeah, it is too common, unfortunately, right? We shouldn't be doing all this. As simple as we shouldn't be even letting our mouth open when we sleep at night. How tough is that? How tough is that? Right? So onset is insidious, even for adults as well, occur at any age. All healthcare providers should have very low threshold to detect or at least to send for testing. We need to screen, right? We need to check for all our patients, young and old. And of course, we have a whole workflow here. You can always refer back to the research paper. If you can contact the same QR code just now, we will be able to share all this paper. But I think, again, is to just look at how integrative and inclusive it is now, right? To include the dental perspective in the whole management. So we have, right, mandibular advancement device, we have oral myofunctional therapy, we have maxillary expansion, right? I put a question mark on rapid because I don't do rapid, but sometimes I still do it, like say, it is fast, but you don't have the intention to just split your whole jaw quick. I don't think we need to, right? Especially working with children especially, I think we can really tap on their growth potential. And for adults, thankfully, we can't grow, but we still can repair. So we still have a chance. But then another part about the sign of obstructive sleep apnea, again in the paper, you noted quite a few things are actually all dental related, right? So you are looking at small jaw, high arch, palate, the tongue blocking the whole back of the throat. Then the Manapati score is really high. You have crossbite because sometimes you have a lateral side is underdeveloped due to tongue not extending up and spreading the upper jaw, right? Or it can be the reverse on the interior crossbite. Increased overjet when you have a very deep bite, and short lingual frenum. So it was mentioned in there, orthodontics has its role, right? So again, everything is still evolving. This is already 2017 paper, right? I think we can recognize that we can definitely expand the arch, change our class 2 to a more mandibular advanced position, expand our arches as much as possible, line them up, get a good curve of speed correction, good posterior vertical. All this is what we can aim for when we do orthodontics for a patient, not just for straight teeth alone. Then of course, because I treat my TMD patient for the past 14 years, I'm doing sleep for the past 6 to 8 years, I'm very mindful, I don't want to close the volume for them. So that's why when I do my orthodontics, I also try not to extract any teeth. Or should I say I don't at all, right? Then how do I get my result? I'll show you. All right. So myofunctional therapy, definitely, yeah. And all the other papers that were already discussed earlier. Phenotyping. So we discussed here, so for Stephen Lambert, he came out with this paper where we're looking at, yes, most of the time we're only in the blue zone.